All right. All right, so respiration, artificial ventilation. So this one is a pretty deep chapter. If you didn't read it, you're missing a lot. Be a good chapter for a pop quiz. Was. All right, so we're going to talk about oxygen use. We're going to talk about nasal cannulas and non-rebreathers and BVMs. The big thing, this is that chapter. This is like that first thing, the list of 10 things all EMTs should know at the end of an EMT class. This was number one, which was the difference between inadequate and adequate ventilation, right? By far, one of the most important things you'll take away from this. And then we're going to beat oxygen to death and tell you how horrible and dangerous it is so that you don't give it to the wrong people, okay? So let's see here. Pathophysiology-wise, these are good flashcard stuff, right? Ventilation is the process of moving air in and out of the chest. As an EMT, you will artificially ventilate patients, right? Because you use a BVM, you'll use CPAP, you use mouth-to-mask or whatever, okay? There is no way for us to artificially respirate somebody because respiration, I'll come back, don't worry. Thought it was there. Guess not. Respiration is the exchange of gases, right? Ventilation is the movement. I don't know where the respiration thing went. Ventilation is the movement of air in the lungs, but respiration is actually the exchange of gases, gaining CO2 and gaining oxygen and getting rid of CO2. Does that make sense? I had 2 hours of sleep last night, but a lot of coffee. I'm really going to apologize ahead of time. It was a very long night. What's that? 3.5 inches of snow in 6 hours in Deer Park always is an entertaining ordeal for people who drive like idiots. So, other one to associate, we talked about this before, right? Inhalation is the active process causing negative pressure. Okay? However you keep those three together, you're going to see test questions on the next test, more than one, and they will find ways of putting this into every single test for the rest of this class, and the NREMT loves this. Okay? Inhalation, active process, negative pressure. Don't forget it, love it, know it, memorize it. The other side of that, obviously, is the exhalation, right? Exhalation, passive, positive pressure. Exhalation is when things relax, right? It doesn't really have any work with exhalation. Exhalation is just that passive process. Now, the thing to remember is we normally are used to getting our inhalation from a negative pressure. So when we use things like BVMs and CPAP, we're messing with our body's natural ability to breathe. Okay, we're going to talk about the side effects. We're going to talk about how to avoid those side effects and how to look for the side effects in case they happen. One of those slides that's all in red. Okay, tidal volume we talked about, amount of air moved in one breath. Okay, your textbook is going to say normal tidal volume, about 5 to 7 mLs per kilogram. Okay, average tidal volume on an average adult weighing the average amount is about 500 mLs. Okay, if you want to figure out somebody's tidal volume that's meant for their body size, take their weight, divide it by 2.2, which puts it into kilograms. You times that by 7, and it'll tell you how many milliliters is supposed to be in one breath. Okay? That never happens at the EMT level. Be thankful for that. The really unique circumstances if you were using an automatic transport ventilator and you, for some reason, had to figure out tidal volume, that's how you'd figure it out. Okay? This is more or less, there is a question on your homework. There may or may not be a question on your test related to that. Okay, minute volume is the amount of air moved in and out of your lungs per minute, right? We take the respiratory rate times the tidal volume, and we end up with minute volume. Or the stuff we talked about back in, like, what was that, chapter 7? All comes back. Make sense? More good flashcard stuff. All in red again, except for that. So, dead space, right? We talked about that. Don't write of gases, just a waste of your ink. So, dead space is the amount of air that doesn't actually reach the alveoli. Okay? So that's about 150 mLs. We talked about this, right? That never changes. Your tidal volume can go up and down, but your dead space never changes, okay, because it's an anatomic thing. So this is the number to always think about, whatever your tidal volume is, to actually find out. The term is alveolar ventilation, how much air is actually reaching the alveoli and participates in that gas exchange. You've got to get rid of that tidal or that dead space from your tidal volume. Okay, more good flashcard stuff. Diffusion, movement of gases from high concentration to a low concentration. Okay, that's also a term you'll see on a regular basis. This next test has a pretty good mix of knowledge recall, which is this stuff, right? What is dead space? What is alveolar? They find ways to ask you that. And then it's a decent mix of some practical application stuff with some critical thinking. Make sense to everybody? I'm dragging my feet for a few more seconds. Any questions so far? I know we're only 5 minutes into 137 slides, but might as well ask them now. Gets more fun. So these two, for whatever reason, these tend to confuse students on test questions. External respiration, this happens between the alveoli and circulating blood. Okay? Internal respiration is the actual exchange of gases between blood and cells. Okay? So obviously oxygen travels into the alveoli, then it goes into the bloodstream, which then we look at internal respiration for it to go from the blood into the cells. Does that make sense? More good flashcard stuff. And this will be on your next test. I would probably, if I had to guess without looking at the test, the last 4 slides is probably close to 20 test questions. Okay? That's why it's all in red. Flashcards, study, repetition. If you sleep on your textbook, it helps. Osmosis. Usually do it, inadvertently, but it helps. I don't know. That's how I learn stuff. Yeah, it does transfer. Just make sure you put cotton in one ear so that way it stays inside. You don't want it to fall out when you get up. That's the secret, man, I'm telling you. Yeah, for sure. I can see some of you writing it down right now. Sleep on textbook with cotton in left ear. Good? Cool. So cellular respiration, okay, the nice thing is this is as far as we go. Okay, be thankful for that, because if you've taken like chemistry and all that crap, this is miserable. Okay, know the definition. Okay, forget about it from there on. That's the good news. You go to paramedic school, this is like a week and a half, which is worthless. No reason for that. We're almost out of the boring stuff and into the fun stuff. And then we go back to the boring stuff. All right, so let's look here. So respiration. So write these two terms down. I don't care where you write them, but by the end of this chapter, if you still do not have a good grasp between the difference of adequate versus inadequate, I want you to raise your hand. We're going to start over at slide number 1. Okay? People are like, no one raised their hand. Just kidding. In all seriousness, you've got to understand this. Okay? I will tell you probably a quarter of your NREMT will all be about adequate versus inadequate breathing. Okay? On your next test, almost the entire test will be about adequate versus inadequate. Okay? And airway's number 1, right, which we talked about. This is breathing, so which is our number 2 priority. This is huge. If you don't pick up on inadequate breathing, people die. Okay? Pretty easy, pretty straightforward. So hypoxia, we've talked about before, low oxygen level in the cells. Okay? We've got ways of correcting hypoxia, which we'll talk about. Carbon dioxide must be continuously removed. If you're not breathing, you retain too much CO2. Okay? So with hypoxia, normally comes hypercapnia or hypercarbia. They use those terms interchangeably. Okay? The more CO2 your body recognizes, the more it wants to breathe. Okay? When we start talking about diabetics, we'll talk about head injuries, and we'll talk about today, when your body starts to have an increase in CO2 and your body becomes acidic, your brain makes your body breathe faster to blow off CO2. Okay? Those are big red flags we're going to talk about throughout this class. So your whole purpose, right, is to assess how well your cardiopulmonary system is accomplished in oxygenation and carbon dioxide removal. That easy, right? No big deal. Whole job right there. So how are you going to do it? How do you assess your cardiopulmonary system, and how do you know you're getting oxygen, and how do you know you're getting rid of CO2? What are the things you're going to look for? Color. What else? SpO2 stat. What else? Heard something else. Breathing rate, right? What else? You've named all the respiratory stuff off. What about the, yeah, so pulse rate. What else? Temperature. What else? Blood pressure. What else? There's more. What about your level of consciousness? Right? Are you conscious? Can you answer person, place, time, and event, or are you altered? Right? If you're altered, my first thought is you're suffering from hypoxia. Okay? So all those things throughout every patient contact is the things you're going to be looking at. So the nice thing, right, when your oxygen levels get low and your CO2 levels get high, it's extremely predictable. We know what this looks like. Okay? The one of the things that we can tell right off the bat is this right here. You can walk into someone's house and you should be able to pick this up that quick, right? Their perception is shortness of breath. That's why it's a symptom. It's something they tell you, right? Signs are things that you can see. Symptoms are the things that you're being told, okay? So you walk in the door and they say, I'm having shortness of breath, okay? Should be your first red flag. Then you recognize a high respiratory rate and depth, right? They're trying to blow off CO2 and gain more oxygen, okay? Why does their heart rate increase? If we're talking about oxygen levels or CO2 levels, why do we increase our heart rate? Yeah, so you got to get the CO2 to your capillaries faster, and then you got to get your oxygen out of your capillaries to your body to compensate for that, right? So your respiratory system and your cardiovascular system always work together, okay? This is the predictable side. So in the beginning, it's nice because your body is meant to have those compensating measures. It can survive with lack of oxygen for a few minutes, right? You get stuck in a plastic bag for whatever reason, you can survive for a minute or two until you burn up all that oxygen. And then your body's going to start decompensating, right? We should try to pick up on this if we can right here. So respiratory distress is our body's compensating measures, okay? Think of distress and adequate as being the same thing, okay? Adequate breathing is really easy. The treatment for adequate breathing is supplemental oxygen. The treatment for inadequate breathing is positive pressure ventilation. If they're inadequate, you're never going to give them 2 liters nasal cannula. If they're inadequate, you're never going to give them 15 liters non-air breather, okay? That's why once you understand the differences, the treatment's extremely easy. Adequate breathing gets oxygen or nothing, right? Inadequate breathing gets either a BVM or CPAP. It's the only 2 options. Okay, so those test questions, you really got to make sure you're looking, is it adequate versus inadequate, which is what most of this slide's all about. Okay, so here's inadequate. So the challenges of that compensation are too great and things start to fail. Okay, can you be alive and be in respiratory failure? Yes, right? It goes normal, distress, failure, arrest. Okay, arrest means without. Okay, so adequate breathing is distress, right? You show up at someone's house and they're having difficulty breathing. They're conscious and alert. Their skin's normal. Their rate's elevated but still within normal limits. Their tidal volume is still decent. Their stats are still good. They're talking to you. They're in distress, right? They may feel like they can't breathe, but currently they're in just distress, right? Let's say you don't pick up on the signs and symptoms. Now the patient is in and out of consciousness. The patient is breathing too fast to maintain good tidal volume. Their tidal volume is garbage. Their SATs have dropped below 90. Now they're pale or they're blue, and they're laying on the ground. We've now transitioned to failure, right? Now, if you still stand there with your hands in your pockets, and they quit breathing, they go completely unconscious, their SATs drop, let's say, into the 80s, their heart rate starts to plummet, their blood pressure starts to drop, we're talking about arrest. Does that make sense? we've got to pick up on this in that distress phase, okay? So what do you think? Distress, arrest, or failure? Distress. How would you know? Touche. Note to self. Get rid of captions. Okay, so let's say that doesn't say distress. How else would you know? Sucker. So body position for sure, right? She's in what position? That close. Tripod, right? Sniffing is actually chin up high, right? So she's in the tripod position, but what else keeps her away from failure? Say again? So she's on O2, right? But that could just be an idiot EMT. So that doesn't guarantee it. What's that? She's conscious, right? I don't see any cyanosis. She looks sick for sure, but I don't see any cyanosis. I'll bet I'm going to go on with Melville in the fact that because of the fact that she's on oxygen, her rate must be decent. It's probably fast, but it's decent. Her tidal volume might be low, but still within normal limits, right? This is a sick patient. This patient needs help, but this patient is not in respiratory arrest or respiratory failure. Okay? So here's adequate breathing. When you have test questions, I don't know how you want to write this down, but you need to write it down. When you get a test question that's trying to figure out is it normal or is it adequate versus inadequate, I want you to look at these things in the test question. If you want to circle them, underline them, whatever. Okay? If your test question wants you to determine is it adequate versus inadequate, you've got to find in that test question if you've got enough to prove one or the other. Okay? So adequate breathing, this is the distress side. Okay? Normal mental status, normal pulse ox, normal skin color. There's more after this. Just those three for right now. Normal mental status, normal pulse ox, normal skin color. Normal mental status means you should make eye contact when I walk in the door, and you should talk to me about me without me having to talk to you. Okay? Normal skin color, warm, pink, and dry. Okay? Not cyanotic. Normal pulse ox, anything above about 90%. Okay? Anything less than 90, we start getting concerned. Make sense? We're going to add to a couple of these here in a second. So here's inadequate. Okay? Clearly, chest movements are absent, minimal, or uneven. That's easy, right? That's a tidal volume issue. Breath sounds are diminished or absent. Okay? No air can be felt or heard at the nose or mouth. Wheezing, crowing, stridor, gurgling, gasping during breathing. Yeah. This one's got a long list after it. So write these ones down for starters. So chest wall movements inadequate or not normal. You can't feel anything, or there's an abnormal sound. Basically sums up those 5 bullet points. Make sense? Give me a few more seconds. Good? Awesome. So rate of breathing is too rapid or too shallow. Anything over a rate of 28 is too fast. Okay? Breathing rate is very shallow, very deep, or appears to be labored. Okay? Cyanosis, which means blue. Inspiration or expirations are prolonged. Retractions and nasal flaring in children. This is going to say less than 95%. We're going to talk about, we might slide that a little bit farther away. Okay, you can write it down for now. So rate of breathing is too rapid, too slow. Cyanosis, lack of oxygen saturation or low oxygen saturation readings. Cyanosis. Anytime your test question says it's a shallow or slow rhythm or rate, it's automatically inadequate breathing. Okay? NREMT loves that. Patient's rate is slow, or the volume is low or irregular, blah, blah, blah. That's the key phrase, right? They're pointing you towards inadequate. Okay, basically if they mention any of these 2 bullet points anywhere in the test question, it's inadequate.
What are we talking? Well, like,
Less than 8. So over 28, less than 8. The way we used to always we talk to paramedics is less than 8, intubate. You can intubate, but just keep that in your head, right? Any less than 8 is going to get a BVM. Make sense? Good? All right, so hypoxia, which is low oxygen intake, right, or low oxygen in the bloodstream. Major causes, they throw a couple of these out here. I don't know why they're so specific, but patient trapped in a fire, patient with emphysema, overdose on a drug, patient has a heart attack, and then all the other hundreds and hundreds of things that causes hypoxia. Please don't assume it's only these 4 things, because there is more, plenty more. So let's look at number 1, just for now. So patient trapped in a fire, how are they suffering from hypoxia? Less oxygen in the air, right? That's pretty easy. What about emphysema? Anybody know the pathophysiology of that? What's that? So lack of alveoli, which leads to less oxygen going in the body, right? How does something like heroin or an opiate or oxycodone, hydrocodone, tramadol, any of those kind of things, these overdoses, how do they mess with hypoxia? They mess with your respiratory rate, right? A patient that has a heart attack, how does that create hypoxia? What's that? Lower movement of your blood, right? Because the heart tissue starts to die, and now your heart doesn't pump like it's supposed to. So, this is what we talked about. Inadequate breathing, the only treatment, I'll say it again, the only treatment is artificial ventilation. Okay? Your patient is breathing, and they are adequately breathing, but complaining of difficulty breathing, then we can give them some supplemental oxygen. Okay? But inadequate breathing patients get artificial ventilation. Okay? I will tell you in Spokane County, we've changed this because of our CPR guidelines. Okay? Because of the fact of we've got some proof that shows how horrible we are in EMS in Spokane County with our BVMs, that we are going to, if we got 2 or 3 people doing CPR, that's our crew. We actually put non-rebreathers on our cardiac arrest patients and just do chest compressions, right? Because good chest compression should cause positive negative pressure and pull oxygen out of that non-rebreather, which eliminates that BVM position. If we've got 6 people, great. You can put 2 people on a BVM and you can do it adequately. But if you only have 3 people, there's not enough hands, right? We're going to talk about BVM use here in a second. Everyone thinks that because you're an EMT, you can use a BVM. I'll tell you about 80% of the EMTs that I work with do it wrong every single time. 90% of our paramedics can't use a BVM, right? They don't get a good seal. They do it inadequately. They do it improperly. They're causing more damage than they're causing good, right? It's a big deal, but we all think, it's no big deal. You squeeze the bag. There's a ton more stuff that's involved with it. So interventions, right? Again, we've talked about airway and about how to be aggressive with airway control. Breathing is about the same aggressiveness. So if you pick up on inadequate breathing, it's something you fix right away. It's not something you wait. It's no different than airway. If they had an airway problem, you wouldn't skip it and move on and come back to it later. Breathing is the same thing. If it's inadequate, you fix it right now. Positive pressure ventilation, oxygen, whatever the case might be. I don't like the first bullet point very much, but it's trying to put a point across. Your respiratory failure patients can still be awake, right? They're altered almost every single bit of the time, but they are still conscious for some period of that. So don't just think because their eyes are open that means they're breathing just fine. Dead people have open eyes. All right, so here's positive pressure ventilation, all about BVMs. So these 2 bullet points, you don't have to write them down, but of fundamental skills employed by EMS, few are more crucial to be able to ventilate the patient. provided there is adequate gas exchange at the VLI level and adequate circulation of the tissue, you can artificially ventilate with a BVM indefinitely and keep them alive, right? As long as their body will do the respiration piece, you can artificially ventilate someone forever, right? That's the purpose of ventilators. You get brain dead patients who sit in a hospital for 3 and 4 or 5 days, weeks or months, who have no breathing power on their own, but if they're on a ventilator, you can keep them alive, right? This is pretty important, okay? This is one of the things that we give to our patients that provides that time frame between our scenes and our hospitals, right? This is that prolonging death long enough to get them to a doctor, okay? That's huge. So positive pressure ventilation, you'll see it as PPV a lot of the times, okay? Forcing air or oxygen into lungs when a patient has stopped breathing or has inadequate breathing. Again, this is the exact opposite of how the body normally obtains air into its lungs, okay? So if you read the chapters, what are the side effects of positive pressure ventilation? Low blood pressure. Yeah. Gastric distension, which is what? Air in the stomach, which leads to what? Which leads to airway problems, which leads to you puking on them, right? So, what's that? Hyperventilation, which we're going to talk about the dangers of that here in just a second. Look at that. No? You asked, I thought I'd tell you. I don't want to go back. I guess I can. Don't worry, the whole next slide's red too. Could have given you a pop quiz. Everyone's like, yeah. Everyone shut up. Don't do it.
Or you could not.
Good. We good? All right, so we covered the drop in blood pressure. We covered the gastric distension, okay? So hyperventilation, they pulled a bunch of statistics from Washington State and found that Washington State has one of the highest save percentages of cardiac arrest, right? Seattle beats us every single time for other reasons, and we're pretty close to that, right? So here's the downfall. We're amazing at getting people alive with blood pressures and heart rates to a hospital after cardiac arrest. We have one of the highest rate of brain dead people sitting in ERs and dying there, right? So we were like, that doesn't make any sense. This is why, okay? When you hyperventilate somebody, so you've got pure oxygen, you stick it on their face, and let's say you bag at a rate of, you squeeze the bag every 3 seconds, which is about a rate of 20 breaths per minute, okay? So you're pumping 100% oxygen there. What happens to the brain? So it gets over-oxygenated, but what does that do? Causes all the vessels to shrink, right? So it's oxygen is a vasoconstrictor. So all the vessels in the brain shrink down and start shunting blood away from your brain. So now your patients are brain dead. We can perfuse the heart and the lungs perfectly because we're pumping on the chest, but by hyperventilating, we're actually causing decreased perfusion in the brain. So we get a heart rate and a blood pressure back, but our patients' pupils are fixed and dilated. We get them to hospital. They won't breathe on their own. They get stuck on a ventilator. They call family. Family comes in and says, unplug them, and they die, right? Washington State, highest save percentage for cardiac arrest, highest percentage for hyperventilation. So we were like, well, it's real easy. Just teach people to count to 6 and squeeze the bag. Wrong, right? Because when I was an EMT, when I took my EMT class, they were like, every time you breathe, squeeze the bag, right? On cardiac arrest, you're breathing and you're just squeezing the bag, right? And I was like, oh, okay, so let's count to 6. So 1, 2, 3, 4, 5, 6, bag. 1, 2, 3, 4, 5, 6, bag. Doesn't work. Now we've gone one step farther, and City Fire just went and bought these little lights that stick on the BVM that blink every 6 seconds, right? You tell these dumb firefighters, squeeze the bag when the light turns green, right? And these big buff firefighters are like, ooh, I could do that. And they just squeeze the bag when the light turns green. Problem solved, right? They had the idea of making the monitor beep every 6 seconds. The problem is you got the monitor beeping for a rate of 100 for chest compressions, a monitor beeping to tell you when it's going to shock, and a monitor beeping when it's supposed to be bagging, people are bagging at a rate of 100, right? So this was the big deal. We used to do really bad in the EMT class where, people would get in the class, they'd grab the BVM, they'd bag the mannequin, and they'd bag it like bag, 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 and they'd go, don't worry, I wouldn't do that in the field. And I'd be like, okay, yeah, no big deal. If you do it here, you're going to do it there. So in this class, I will always tell you to slow down, right? Know what 6 seconds is like. You should also be able to have the rhythm of 6 seconds and be doing 2 other things in your head, okay? Because in the field, you're not going to just be like, okay, I just got a bag. Bag 1, 2, 3, 4, 5, 6, bag. You're doing a million other things, right? You're doing with family, you're doing with your team, you're doing with whatever. So you have to find a way to make that like second nature, right? You don't have to think about that. It should be just bag, count to 6. Bag, count to 6. Bag, count to 6. And you should be able to do that without even having to think about it, okay? That's huge. One of the things that $125,000 mannequin gains us is it times your respirations. When you're bagging, I can tell you how much air you're pushing in the chest, how long it took you to squeeze the bag, and how often you are bagging. So I can tell you, for one, you're only giving 450 mLs, you need a little bit more. It's taking you 0.5 seconds to squeeze the bag, squeeze it slower. And you're giving a rate of 25 per minute, slow it down, right? That's one of the reasons we have that mannequin, is it allows us to correct you at the basic level, and we can fix it what you do in the field. Does that make sense? Metronome, what's that? They do. That was the only downfall, was with a chest compression metronome and a ventilation metronome. We were worried that it would mess with, what's that? They do. But like I said, but if you're getting one and one, but the chest compression one works awesome. But then putting another noise to ventilate, that's why they do lights.
Our AD has one.
Does it?
It takes a minute to ventilate.
That's annoying.
Okay.
See, like I said, even dumb firefighters can figure it out. Just kidding. Obviously, if they're puking or they have vomit in their airway, you can't ventilate them, right? That's dumb. So make sure you suction first. Every single time you squeeze the bag, make sure the chest rises and falls, okay? You should pick up on the fact that it's not rising and falling, okay? The last thing you want is your partner to be like, hey, you're not getting chest rise and fall. How long has it been like that? And you go, oh, right? Every breath, chest rise, chest fall, chest rise, chest fall. So write this down. It's very important. Adults without an advanced airway, you're going to bag every 5 to 6 seconds. If it's children, infants included, every 3 to 4 seconds. Okay? This is a rate of about what? How many per minute? 20? Man, counting real hard. Right? 10 to 12. How many is this? 20. 20, right? 10 to 12 per minute for adults, 20 breaths per minute for kids and infants. I hope there's no adding on the next test. Goodness. It was single-digit numbers. He was all right. Make sense? Every 5 to 6 seconds for adults, 3 to 4 seconds for kids. Good? All right, so techniques of artificial ventilation. If you are bagging, I use the term bagging. It's not like a mean term. Sorry if you're offended. Bagging a patient, and they are conscious, because there are those unique times, right? Rate of 28, they're kind of in and out of consciousness, but you decide you have to breathe for them. So the patient who can't breathe, who feels like they're suffocating, you're going to stick a mask on their face that's plastic, and you're going to blow positive pressure ventilation in their face, right? You have to talk to them, okay, because this is a miserable, miserable experience. In fact, today, if you want, we'll lay you on the floor, and we'll let you bag each other and see how much fun that is, okay? It's a total mental thing that messes with you. So you're going to be talking, I'm going to try to breathe for you. Do me a favor and try to time your breath with what I'm doing, right? Because you want them to slow their own breathing down, okay? Because they're breathing at 28 times a minute, you're going to bag every 6 seconds. Even though they're breathing 28 times a minute, you're still going to bag every 6 seconds. Does that make sense? Nice and easy, good mask seal, talk to them the entire time, and go from there. A lot of times you'll see CPAP as non-invasive positive pressure ventilation, NIPPV, okay? So this class we talked about continuous positive airway pressure, right? That was the rabbit lung video I showed you, and it's in here again. But this is that CPAP. We put CPAP on what type of patients? Adequate or inadequate? Inadequate, right? Adequate, there's a unique time you may use it, but it's pretty rare, right? Now, if the patient is in respiratory arrest, can you use CPAP? You can't. They have to have a spontaneous breathing rate. Okay? CPAP is not meant to be a ventilator. Okay? Remember how this works or what this looks like? These are the rabbit lungs. The power of YouTube has changed my teaching career. Seriously. Right? So this is where they turn that PEEP on, right? This is that CPAP. And then a little bit higher. And a little bit higher. And they're going to break that CPAP level. All the way back down to 0. Right? So one of the ways, I will tell you in this job, you are not going to do mouth-to-mouth CPR. Okay? Sorry, if that's why you're here. I'm really, really sorry. Right? We don't do it anymore. Why don't we do it? 2 reasons. It's gross and it's stupid. Right? There was a horror story that came out, I think it was a year or 2 ago. There was a lady in District 9's fire district, a layperson, who hit the guy in a crosswalk with her car. Right? Whacks him. She feels bad. She gets out. She checks her pulse. He doesn't have a pulse, so she starts CPR and she does mouth-to-mouth on this guy. Right? EMS arrives. Transport him. He's bloody. He dies. Okay? EMS notifies her that he's a frequent flyer and he's HIV positive. Guess what she has? HIV. Right? Those are the dangers. Can you do CPR without mouth-to-mouth? Yes. Is it just as good? Yes. Right? Forget it. Don't worry about it. In EMS, you're going to breathe for people. Either you're going to use a BVM or you're going to use mouth-to-mouth. We do not do mouth-to-mouth in EMS. Okay? It's not worth it. That's a mask. We recommend if you're going to use these to have a one-way valve, right, that allows you to blow air in, but whatever they had for breakfast, lunch, or dinner, not to come back into your mouth. Okay? You should also be wearing gloves, and I would encourage you to wear goggles. Okay? So if you have one of those cool jump kits in your car, this is a really good place for your mask. Right? You don't need to carry it in your pants or in your uniform because we got stuff better, but this is a really good place. How many of you carry a pocket mask? Anybody carry in their car? Put a pair of gloves with it if it doesn't have it. Okay? Because you almost always use them hand in hand. Okay? So mouth-to-mask, patients without suspected spinal injury, this is really easy, right? We talked about the airway position being at the head, right? The crown of the head, not to the side. It's real easy. You just breathe into the mouth. You inhale. You exhale into the mouth. You inhale. You exhale in the mouth. That's easy. Okay? If you're doing this for a patient who's not breathing but is not in cardiac arrest, so they still have a heartbeat, how often do you think you're giving them breaths? Every 5 to 6 seconds. Doesn't change. Whether you're using the BVM or not, your rate never changes. So BVM, bag valve mask, or you'll hear us use the term bagging, right? Handheld ventilation device, we use this non-breathing patients or patients who are in respiratory failure. That's a BVM, okay? There's infant sizes, there's child sizes, there's adult sizes, there's even a neonate size that's even smaller than this one, okay? Tiny. Let's see here. Feature-wise, let's go back. So you got the mask here. You got the bag. This is an O2 reservoir that allows you to hook this up to 15 liters, which fills this with supplemental oxygen. So when you bag, it actually pulls it out of here and fills this with oxygen. Can you use a BVM without supplemental oxygen? Yes. Right? Let's see here. So American Heart Association will tell you that BVM is a 2-person job. Okay? Statistically, this is the reason why EMS can't use it. They cannot get a good mask seal. Okay? So American Heart Association wants 1 person holding a mask seal and one person squeezing the bag. Okay? This is why in systems that have low numbers of people, we've stopped using the BVM during cardiac arrest. Okay? Because we just can't provide 2 people to do a one-person job, right? So we've gone to the non-rebreather with cardiac arrest. This class, when we get into cardiac arrest, we'll talk about that way. You can make your choice, but no, on the NREMT, that's not an option. Okay? It's only a Spokane County. It's other places, but it's only a Spokane County thing. Got to make a choice. I will tell you, head tilt, chin lift, and holding a mask seal is super easy, right? If you have to do the jaw thrust maneuver, then you have to have 2 people for this, right? You can get away with 1 person with a head tilt, chin lift, but 2 people to hold that jaw thrust, there's no way to do that with 1 hand. You definitely have to use 1 person to hold the jaw thrust and the mask seal, and 1 person to beg. Okay, we're going to mess with this stuff when Kayla gets here. So that's that jaw thrust. We're going to talk about that. Don't worry. Artificial ventilation is someone that has a stoma, right? A surgical opening in their throat to bypass the upper airway. Appropriate rate for patient's age, okay, whether it's child or adult, or the case might be. Some of them have a trach piece that sits there. You can actually attach your BVM to. If they just have a surgical opening, you take a pediatric mask and put it on your adult BVM and just place that pediatric mask over that hole and just ventilate like normal. Okay? If there's actually a trach piece there, to take your mask off and attach your BVM right to it. Does that make sense? So this should be in red because these are the 6 do's and don'ts of using a BVM. Okay, this is the stuff that I'm super critical of. Okay, first one is you've got to pick up on the need to ventilate. Okay, if it's less than 8 or less than 300 mLs per breath, which that's just going to take a guess, you're going to bag them. Right? The reason why I didn't put up 28 up there is 28 is kind of subjective. Right? A 17-year-old who just got in a fight with their parents, and the parents kicked him out of the house, who's breathing 30 times a minute, and then you take a kid who's got stung by a bee, who can't breathe, who's breathing at a rate of 30 times a minute, which one would you bag? The kid, right? The 17-year-old, yes, it's over 28, but it's circumstantial, right? They're stressed, there's some adrenaline there, let that stuff wear off. They're hyperventilating, they're not having respiratory distress. Okay? Breathing always starts with airway. Everyone wants to forget the fact that every time you use the BVM, either head tilt, chin lift, or jaw thrust, if you can't figure that out, OPAs, NPAs. Okay? We're going to use SimMan today with the BVM, and I'll show you how every time concentrate on that airway maneuver. Okay? If you're having a hard time, that's what the OPAs and NPAs are for. Proper size mask, okay? You've got to use adult mask on adult, kid mask on kids, pediatric mask on pediatrics. I will tell you one of the reasons why we leave dentures in place. If you take out someone's dentures, you lose the required structure it takes for us to get a mask seal. Right? It's really, really hard to get a mask seal on someone without their teeth. Okay? So if the dentures are not a problem, leave them in place. So big things, chest rise and fall every time. How long should it take you to squeeze that bag? 1 second. How long should it take you to squeeze the bag? 1 second. How often are you squeezing the bag? Every 5 to 6 seconds. Right? What happens, do you think, if you squeeze that bag in half a second? So too much air. So what does it cause? Gastric distension, low cardiac output. What else? Hyperventilation. It also usually messes with your seal. Right? 1 second. Nice and easy squeeze. If you get a lot of resistance, your airway is not open. Okay? Those are the things you got to note. So here's the 4 don'ts. Okay? You don't allow air in the lungs if you don't keep the airway open. The other one is you should be pulling the jaw to the, or you should be pulling the patient to the mask, not pushing the mask onto their face. Because if you think about that, if you push that, even at head tilt, chin lift, if you push that mask straight back, you're pushing that lower jaw and occluding their airway. Okay? Bring their face to the mask, not the other way around. if you can't maintain a skill, be the first person to be like, I can't do it. Right? Get help. We have ways to teach you. Overventilating and hyperventilation. Too much air causes gastric inflation, which increases your chance of vomiting and airway problems. And then too fast is you're decreasing perfusion of the brain and you're causing brain damage. In cardiac arrest patients, this is not a good thing. In all patients, not a good thing. So remember how we talked about increased cranial pressure, right? We talked about bleeding on the brain causing your brain to swell. Believe it or not, we now have protocols that allow us to purposely hyperventilate patients who are herniating. Because if their brain is swelling and getting shoved down that hole in the back of their skull, if you hyperventilate them on purpose, you actually cause their brain to shrink, right? Which in normal cases would be a bad thing, but in this case, the brain is swelling, causing damage, so we do it on purpose to reverse that effect. It's the only time we hyperventilate. So, in this class, this is what I ask of you. Take BVM seriously. Okay? Watch for chest rise and fall. Pay attention to your seal. Look at how long it's taking you to squeeze that bag. Look at your rate. Look at your volume. Look at all of that. Right? Because if you do this incorrectly, you can accelerate hypoxia. Exacerbate means you make things worse. Right? You can mess with that airway obstruction, and then it can obviously will result in serious injury or death. Okay, how sad is it that we are known in the medical side of things of saving people's lives in the field but giving them a life-threatening problem to take with them to the hospital? Right? That sucks. If we would just fix hyperventilation, we'd probably do a lot better. Let's take a quick break. Stand up, stretch. We're going to talk about devices here in a second. For sure.